to our educational session for this month. And it's going to be a very interesting theme, CT-oriented body composition analysis in pediatrics, Wilms tumor, advancing precision nutrition and personalized oncology care. We welcome two colleagues from Brazil in the state of São Paulo. That's Mariana Murra is a dietitian and Wilson is a physician. They both collaborate with us that work with IPAN, and it's been a great collaboration, a few years. And I'd just like to welcome everybody and remind you of our nutrition research forum that we're having right after the SIOP Congress. That's going to be in October 24 in a city very near Amsterdam. So if you are interested, just please look up that information in SIOP Connect, and you can find all of the information to register for that event. So thank you very much, Mariana and Wilson, for joining us today. And just please start your lecture.
Thank you, Karina.
Thank you, Karina. Thank you very much. Thank you, the SIOP Nutrition Network, for the invitation. It's an honor to us to speak about this very interesting topic that we research about and we are very passionate about. So as Karina said, my name is Wilson. I'm a pediatric surgeon, an oncological pediatric surgeon. And here with Mariana, we are research partners. She's a pediatric nutritionist, dietitian that works here. We both collaborate with IPAN, and we work at Hospital de Amor, Barretos Cancer Children's Hospital, which is a hospital located in a countryside city in São Paulo state, as you can see in the map. And we are known for two main things. The first off is the largest rodeo in Latin America. Mariana, okay, thank you. So we have the largest rodeo in Latin America, and also we have one of the largest institutions in country that treats cancer for free. We are a public institution that takes patients from all over the country, adults and children, and the Children's Hospital started in 2012. It's more than 10 years now. We take patients from all over the country, all 5 regions, and most of them are the Southeast region, the region that we are. And we take in average, this is data from 2021, we took around 500 patients, new cases per year, and around 250 are malignant cases. And all our hospital, it's as you see, it's the name of the hospital is Hospital de Amor, it's Love Hospital. So we have, when the children come to here, this is a public hospital, it's important to say again. And it is not, we want to show them it is not a common hospital. We're more like a mall sometimes looking, because we don't want the children to be afraid of their treatments and all the things is going to happen, because their journey, it's a different journey, right, Mariana? Mariana?
Mariana, you are muted.
Sorry, I was muted. When we talk about the journey of the pediatric cancer patient, is very different when we talk about the adult patient. When we look for different disease or different aids, the pediatric patient, they have different requirement, like energy, protein, and the body composition is very different. Because of this, I like to use the cancer journal for pediatric cancer, because it's very different and we have to look with different forms. And the malnutrition, the children with malnutrition, we have a lot of patients in hospitalization. We have 7.5 until 45% patients with malnutrition. And we know this is not good, and this significant a big impact in prognosis. and is a vicious circle, like cachexia and malnutrition. We have different disease with different behaviors and different body composition. And here, this study did 13,000 patients in children with cancer. Due to its singularity, there is a vicious circles. And how I told, here we can see the percentage of admissions, and here we can see the patients with malnutrition. We have more patients lost 10 years than patients. We have more patients younger. Now, when we talk about the health and children with nutrition, we know a lot of things that can influence in a nutritional status. For example, we have age, sex, nutritional states, hormones, and environment. But when we talk about the children with cancer, we have these points, but we have metabolic changes. And there are still controversies regarding the metabolic changes like hypermetabolism, anorexia, and catabolism that a pediatric cancer patient may develop. Sorry. Talking about this, Elena Ladas, in this study, share with us and how the cancer and the cancer therapy can how is inflammation, and the patient can develop 1 minute, can develop over overnutrition and over undernutrition. And we have a lot of points. For example, poor intake, decreased physical activity, decreased growth hormone, and increased patient fat mass. For the patient develop overnutrition, and undernutrition, the patient decrease fat-free mass, decrease nutrition intake, increase metabolic demand, and growth demands. And
So
Wilson,
we can, thank you, Mariana. So you can open the whole slide, please. Thank you. So when you look into this nutritional imbalances, we can see that malnutrition is just the tip of the iceberg. Because besides malnutrition and many hospitalizations this patient has, Mariana, could you please open the whole slide? Thank you.
yes?
So, thank you very much. So, despite the malnutrition and the hospitalization this patient has, so we cannot forget that he has many other procedures or medications, that he has many prolonged time fasting. There is decreased oral ingestion. He has so many metabolical changes that Mariana was talking about. And also, we need to look to us as LMICs, that we have a delayed diagnosis and treatment for these patients. And also, there's a lot of social inequity. And we did a survey alongside with IPAN. There is a 360 patients here admitted at Barretos, that we use the food insecurity scale from FAO institution, and we find out that those with food insecurity classified as moderate was more than 10%, were those patients with restriction to access to the food, so the quantity that is eat. So comparing to Brazil itself, it's 5.3. Here, children with cancer, we had 10.6. And for severe insecurity, we had 4.1, which is very similar to the Brazil itself. But this data of patients that has difficulty in access food, so they came to us already consumed, and this has an impact in prognosis. This is a study, please, Mariana. Mariana? Yeah, thank you. So this is a study that they looked into the patient with solid tumors and how nutrition support impact in their lives. So patient that had a wafer height percentile that decreased along with the treatment, they had a very, very low survival curve compared to those that did not decreased. So malnutrition and their other diseases, this is a big, it's a big ecosystem of diseases is related and has bad prognosis.
Yes. And when we talk about the ghosts during the treatment, we have a lot of complications and toxicity during the treatment. And we have a war, and when the patient can develop obesity or malnutrition. And a lot of studies did associated with the weight loss during the treatment. And here we understand what the age of at diagnosis, the intensive of the disease can be different during for the weight loss during the treatment. And the children with cancer, they have nutritional disorders, and how Aspen consensus can help us. And in nutritional disorder, the patient can develop malnutrition, micronutrient abnormalities, and overnutrition. For us today, now we will talk about malnutrition. The starvation related underweight, cachexia disease related malnutrition, and sarcopenia. And sarcopenia for us is a big point, an important point for nutrition, and we have to stop this.
So when you look into this is a great study published a few years ago. It's a review study, but they showed us with the most recent evidence that children that lost muscle mass and strength, they lose bone strength, they have a higher risk of impaired neurodevelopment. There's a very new studies from this year. There are some studies correlating dysbiosis and neurodevelopment in children younger than 2 years, disturbances of myelinization, and also the high risk of cardiometabolic diseases because they go high in triglycerides and cholesterol and higher insulin resistance. And when you look into the muscle wasting in cancer by itself, besides all these effects, we have hypogonadism, we have chemotherapy and corticosteroids, we have physical inactivity, we have dysfunction of the thyroid, and also malabsorption disorders and loss of protein. So Mariana, could you please take the slides up?
Yes.
Yeah, the next one. Thank you. So when you look at the children treating cancer, they're in a run. They are competing in a marathon. So and the children who has solid tumor or high risk tumors, they are in the back, very, very, very in the back. They are trying to run and their muscle is suffering a lot because we have the problems related to the treatment, to the diagnosis by itself, and all the losses is going to happen in this point of their lives, which is the early development of the muscle mass by itself. So when they survive cancer, we have aging that is more faster, we have problems in their lifestyles related to the treatment, and the muscle health is going down. So this study, it's from 2020, they compared by decade of life. So in the blue curve, we look into the general population, and the red curve, we look into the muscle health of children who survived cancer. We can see that they're losing very much muscle mass. And this is worse because we cannot forget about the chemotherapy they are going on. Mariana, please. And the chemotherapy they're going on, because the sarcopenia by itself has a higher risk of cardiometabolic disease, and chemotherapy also has a higher risk of cardiometabolic disease. So we are putting things together bad things together. That's not going well. And when you look into sarcopenia by itself in the adult population, this is a very established diagnosis because you see that you lost, Mariana, please, that we lost muscle mass and you lost function. Because in adults, this is a diagnosis generally related to the elderly patients. So how in children we're going to say about the loss of function? Because they did not got the muscle by itself. They're developing the muscle. And if they are losing muscle, so we cannot say that they lost function. They did not get function. So there's some a line of thinking that the patient, if the children is losing muscle mass, despite their function, because they're growing on function, they're sarcopenic. Because the sarcopenic, as Mariana told, is related to malnutrition. And there are many things related, like we are losing function by itself because we don't have muscle to have function. We lose strength because we don't have muscle to have strength. And also, all thinking in cancer, we have an inflammation site. So,
And sorry, Wilson.
please go on, Mariana.
And now thinking how long we have to wait. Costochondrial beating, also known as a rachitic rosary, and we have to wait this point, or we have to interview, or we have to see this before. And this is a adult patient, but now we have patient with a normal composition, and after 16 weeks after they start the treatment, what we can see, the patient lose weight, lose fat, active mass reduce, and extracellular water is bigger. And how we can reduce this process? And now we have a lot of different things methods to evaluate body composition. DEXA is good to remember. DEXA is gold standard in pediatrics, ionization radiation, high precision measures, lean body mass, body fat, body mineral content, high cost, and limited availability. This study included 30 patients and evaluate the time, the sex method control, the timeline of body composition at 1, 6, and 12 months after initiate the treatment, and what they found. Significant increase in body fat during the first month of treatment, with the significance likely associated with induction phase, because they use example on corticosteroids, and this increase was not sustained over time. Changes more pronounced in hematologic malignancies than in solid tumor.
This is an Indian study. Oh, please go, Mariana. Sorry.
No, you can.
Oh, sorry. I thought you had finished. Okay.
No,
So
no problem.
this is an Indian study, a single center study that used a protocol of body composition assessment by Sanjude, and they did a correlation between MUAC and DEXA, and they find in 137 children that DEXA may be related to the arm composition with the MUAC. It's reliable proxy. In this population, it's 137. It's a good number, and they included both solid and hematologic malignancies. And in this looking for next, Mariana, please. Looking for find methods to look for body composition. There is CT and MRI for doing these measurements, because you can quantify, like looking into and doing the full the whole muscle area of the body and divided by fat, looking at the differences of the densities of the CT scans. Thanks, Mariana, please. And this is one of the first studies that did this correlation in cancer patients. It's from 2006, and there was a good correlation between the DEXA scans and the CT scans. One of the newest studies using this methodology is a study from Brazil, was published this year, please, Mariana, and the girls from Inca, and they correlated patients by their age, between 6 and 9 years, and from 10 to 14 and to 15 to 18 years old, patients who were treating lymphoma, and they find that pre-chemo and post-chemo, there's a huge difference in the measurements of the muscle. They lost so much muscle between the chemotherapy and between the whole treatment by itself. So,
Sorry.
When we look into these methods, it's still difficult because we need to measure all body when you look into CT. So looking for more simple methods, the guys from CKids, Mariana, right?
Yes. The guys from CKids, they develop a good reference for us. They develop a pediatric reference values for total psoas muscle areas, and when we can evaluate when the CT in psoas muscle in L3, L4, or L4, L5, and they develop a curve. Since the great variability of children looking to standards measure, there is an amazing work for sick kids in 2020, establish age-specific and sex-specific growth curves per total psoas muscle S. And they developed the curve for kids until 16 years, but when they developed the curve, they excluded patients with cancer from their analysis. Now, we have 41 studies that use this study in reference, and this study evaluate 7 kinds of cancer. Here, we have a lot of studies using CT to evaluate sarcopenia in children with cancer, and what we can talk using adult studies and think some way as who to malnutrition, and what is the standard, and the patient against himself. And we use sarcopenia, z-score less -2, and what this article share with us, reduction in the total psoas muscle area, and we can saw a poor prognosis. Here is a study that include patients with sarcomas, and they evaluate sarcopenia in different moments at diagnosis and until 12 months after the treatment. And the patients with no sarcopenia, they have less number of febrile neutropenia episodes, and we have moderate sarcopenia. And this study have 57 patients with sarcopenia, and the prognosis with the patient with sarcopenia is not good for the treatment. Wilson, can continue?
Yeah. Yes, of course. So this is looking into other tumors that use the Lur's curve, growth curve. We can see this is a study that look into the patient with high-risk hepatoblastoma, and they correlated the sarcopenic patients against non-sarcopenic and find out a great difference in mortality and probability of relapse of these patients. Those who were sarcopenic got worse outcomes. Next one, please. And the same was found in patients with neuroblastoma. Those with neuroblastoma in the high-risk group of treatment, they had a poor survival status. Next one, Mariana. This is another, it's the same study, sorry, but showing that relapse, despite not have a statistic significance, they find a difference between the groups of sarcopenic and non-sarcopenic. Next one. So this study, it's another one of 25 patients with with neuroblastoma high risk, and also those sarcopenic that had poor prognosis. So it's easy to say because we're looking to the bad tumors, right? We're looking to sarcomas and hepatoblastomas and neuroblastomas. Some of these patients, some of these high-risk patients by itself is going to have bad prognosis compared to the others. So we know that they go through malnourishment, but are we looking right to everyone? Are we forgetting of someone? Because when you look, next one, Mariana, when you look into the childhood cancer, we see that everyone will have their muscle lesioned. So what can we do different? So next one, there's always this aura of the Wilms patients that the Wilms is a good boy, right? That when we compare nutrition and the Wilms tumor, the patients will go well most of the time. They have higher survival rates. So the studies that look into these patients regarding nutrition is from the 80s and from the 90s. And also the more recent studies, they are mixed with the other solid tumors because Wilms tumor has a very well-established protocol with very established with good results, and also we have time points specifics of exams, of medications, of chemotherapy. So next one, Mariana. But there are some evidence making us to think different. This is a meta-analysis from the last year that showed that patients who had neoadjuvant chemotherapy go worst in times looking to the sarcopenic. They go more sarcopenic than patients they don't need to neoadjuvant chemotherapy. This is a study from adults. There are no children's study evaluating this. Next one. And this study was published recently as well from the pediatric nephrology team, that they're saying the patients by itself is going to have a bad prognosis. They're going to have proteinuria. They're going to lose kidney function. So I'm going to lose my kidney function. How is my muscle? How is my body composition? What is happening? What can do different of these patients? So Mariana, please. We did a publication. Yes. This is our QR code of our publication that we look into these patients here in our hospital from the last 5 years.
Yes. And for our study, we were observational and longitudinal and retrospective study in Pediatric Oncology Center, Brazilian Children's Cancer Center. We included the patients March 2014 until December 2020. We included patients 1 until 14 years old with treatment by COP protocol, and we evaluate these patients in 3 time points: diagnosis, preoperatorily, and 1 year after the surgery. We have CT image of the abdomen when we evaluate the TPMA, and anthropometrics and oncological features. Here, the image where we evaluate the patient, we can use the L3, L4, but we decide to use L4, L5. Here is the area where we collected the pessoas mass. We use this one plus this one for one patient, and we use the curve to evaluate what's happened with the patient. Here we have the patient before the chemotherapy. The second image is after 4 or 6 weeks after chemotherapy. The moment is the preoperative, and 1 year after the surgery. We selected 72 patients, but we excluded 34 patients because they have bilateral Wilms tumor. They did the surgery in another center, upfront center surgery, tumoral complications, younger than 1 year, we have 8 patients, and another diagnosis. And because of this, we included 38 patients. What we have? In diagnosis, we have 55% of the patients with sarcopenia at diagnosis. After chemotherapy and before the surgery, in the preoperative moment, when the patient do the CT, we have 73, almost 74 patients with sarcopenia. And 1 year after the surgery, we continue with 79% of patients with sarcopenia. And
So this is important to say that when you're looking to malnutrition, we always going to look first at weight, height, or BMI. But when you look into Wilms tumors patients, looking to weight and BMI, they're okay. So Mariana, please, next slide. So look into the anthropometric measurements, they're always eutrophic. But when we look into the TPMA, we have huge differences. In a practical way, we observe the recovery from the adverse effect of the preoperative therapy on weight and height, in weight for age and BMI for age. 1 year after surgery, as we see, they started with minus 0.06, and after 1 year, they are minus 0.11, but they never went malnourished. They never got -2, but TPMA, they lost muscle along the treatment and after 1 year after the end of the treatment. And the same manifestation was of the PMA was in children who lost weight during the in the pre-op period. And as you can see in this graphic, and when we compared those who were metastatic with those not metastatic, the metastatic patients went worse. And those with radiotherapy went worse, those who were local stage 3, because to begin to understand the potential predictive value of the PMA for age, Z-score, and sarcopenia, we look into the temporal variation. And those who received post-surgical radiotherapy and chemotherapy. And those who went into radiotherapy, those who were stage 3 were worst. And chemotherapy, we did not find any association between the schemas of chemotherapy, and there was no correlation between tumor size and reduction before surgery, relapse of the Wilms tumor, death, but we find a difference towards the difference of the length of stay in a hospital with a p-value of 0.05 of those patients who were sarcopenic. So in this way, looking as a CT as an opportunity CT, it is great to say that we did not use the CT especially to do the corporal composition. This CT was done into the protocol, into the patient evaluation, and we take the CT to look into the corporal composition of these patients. And thinking of corporal composition, where are we going now? The systems are going very easy with the time. So now we're talking about machine learning this is a great study of last year. They compared manual segmentation and deep learning segmentation. Deep learning was better than the manual segmentation. And there's a study, next one, that, Mariana, next one, please. They did L3 by CT scans and looking to the specificity of the AI looking for corporal composition, and it was good. They find out great results. Next one, Mariana. So we need to look better into the corporal composition of our patients.
But my question is, this is the LMIC's reality. And we have a lot of studies, and this important study from Brazil. We have body composition, like arm circumference, when we can evaluate, and this can be a good measure for body composition. And CT, DEXA, they are fine, they are good, but this is LMIC's reality, and maybe it's impossible to. And because of this, we have we did a survey in December 2022 when we questioned 31 nutritionists from 12 cancer institutions treating children with cancer. And what we have, and this is a big problem, we have 74% of this team doesn't have less than 5 years experience with children with cancer. 40% of this team evaluate children and adults, and 60% of this team no specific training in pediatric oncology, and 66% body composition is not a routine in the center. And what we have of results, the nutrition
justification.
team. Yes, this is a justification. They work overload. They doesn't have a good communication, and they have difficulties between specialists and lacking of standardization. And take-home messages to conclude our lecture. Understand the corporal composition is vital. Empower your opportunities. For example, in different moments, different disease, they have a CT, or they have to do CTs, and this is a good opportunity to evaluate the moment of the patient in this moment. Significant and fast low muscle mass in the first trimester is crucial because they lost a lot of muscle mass between the diagnosis and the first trimester. Need for research. We have a lot of multi-center, multinational, and survivor research to evaluate the survivors. How do we provide nutritional support, and where is the correct time point to provide nutritional support? And how to preserve muscle mass through the course of cancer treatment. And maybe we have to discuss a lot of this. And Wilson, would you like to?
And it's important to say that comparing to other body compositions assessments like DEXA scans or BIA scans, BIA scans, this opportunity technique for children with cancer reduce the uses of other tests and avoid additional exposure of ionizing radiation. It's more understanding of this TPMA in children with cancer can lead to low-cost clinical interventions, such as optimizing protein and calorie intake, following specific guidelines at this population. At I think the main message we're going to say here, use CT, it's great. It's an opportunity CT. The patient is going to do a CT scan and you can measure the muscle, but Before that, we need to remember, we need to use sometimes just a measuring tape and the children arm. You can prepare yourself what it's going. You don't need to wait to have big muscle loss to do something. We need to do at the beginning. We need to look into this at the beginning when the children start their treatment and the children is diagnosed. So we like to thank everyone for the attention. Thank for the invitation. This is our team in our last meeting, our PEN Brazil in Sobopi this year. And thank you very much for the attention. This is our emails. That's it. Thank you.
Thank you so much, Mariana and Wilson, for this very important topic. I mean, how is our patient's muscle? I don't think we are actually really, we don't know. We don't know. And what is the impact of that? And when do they recover? So these are all things that we don't yet know. And I think we have to do like you're doing, looking at diagnosis, looking at standardizing protocols, to really see, because that may vary a lot between different diseases and in treatments. So I just want to congratulate both of you on the lecture and in the study, and the great work that you guys are doing. I wanted
Thank
to
you, Karim.
open, no problem. I wanted to open for questions. If anybody wants to type or open your microphone, you are welcome to do that. First, I just wanted to ask, while people are thinking and considering their questions, I wanted to just ask, what's your opinion on those Wilms tumor patients? What do you think happened? Do you think it was their diet, the quantity or the quality of the diet? Is it an increased metabolism? Why do you think they became so much more sarcopenic than when they started treatment?
Can I start, Mariana?
Yes,
I
I
love
can.
this question.
I think I think all these points together, I don't know, I think Wilson have the same opinion, but I think it's all this point together. We have a big catabolism, we have the body use protein for like energy, and they lose muscle mass, and we have a bad quality of diet. Probably our patients don't have, probably no, we know they doesn't have a good quality of diet. They eat less protein, they eat less vegetables, fruits, and I think all these points together, we have patients with sarcopenia. But the important point is not just Wilms tumor. We know the Wilms tumor is a good boy, and in before this study, we talk about this, and the patient with Wilms tumor, they have a good body composition because the treatment, it's fine, it's okay, but no, we don't have this with a good cancer. Maybe I can use this for nutrition. This is not very bad, but no, we don't have these results, and this happened the same with the other diagnosis.
Can I add something? Despite
Yes, please.
all Mariana said, I agree with her, but there are 2 points that we cannot forget. First of all, the treatment, it's based in vincristine. I don't know how to say this in English, I'm sorry. But one of the problems of the vincristine is the ileus that some patients has as an effect before after the medication. So this will impair the absorption of nutrients of these patients and has an impact of sarcopenia. I think also some schemes that go bad, especially those with doxorubicin, that the patient, they're more aggressive disease and metastatic disease. And doxorubicin, as we all know, destroys muscle cells. In general, there are some reports and literature and some in vitro studies correlating the lesions of related to doxorubicin in muscle cells, peripheral muscle cells, and the incapacity of coming back the cells again, go to recover after doxorubicin. So it's, I think it's a mix, like Mariana said, but the treatment by itself, despite being good, it's very damaging to the muscles.
Yes.
Yeah, absolutely. We're seeing that. I think there's much more for us to understand. And I think I've heard people say sometimes, oh, but what is the impact in clinical practice if you're using retrospective, images? And I really think it's so important because we need to see what happens, understand what happens, figure out what is the problem so we can just start thinking of interventions for our patients, how to keep their muscle mass, how to recover muscle mass. And I think that is very, very important, that's something that's going to have a huge impact in the patient's life.
Yes.
Direct physical activities as they can do
Yeah.
better nutrition, maybe proactive enteral nutrition. We don't know. We need to maybe understand them better, classify them better, and start like target goals to these patients. If they're metastatic, more protein or more physical activity, I don't know. I think we need to look
Yeah.
these patients in a precision eye.
Exactly.
Yes.
And I want to, if somebody wants to interrupt me and ask something, just please feel free. I just wanted to ask you one more thing. I think I wanted you to talk to everybody a little bit about the measurement of the psoas in the image. So how easy it is to do that? Do you need a special software? Does it take a long time to do
No.
it? What is that like?
No, it's very easy. Mariana, could you please open that slide
Yes.
of that shows the images pre-chemo?
Yes, I
think
can.
it's
1 minute.
Okay.
It's
So
very
we need
easy,
to look.
Karina.
Yeah,
Thank
it's
you.
very, very easy. So first, for Wilms tumor, we chose to use L4, L5, not L3, L4 segment, because L4, L5 segment of psoas, it's more rounded, so it makes it easier to measure. So to do the measurements, you need a freehand tool that some of those softwares that you can use. Thank you, Mariana. One more, the post-chemo, please. I think it's more rounded, it's more easier to see. Okay, here you go. So we have
I
there
will circle.
we have there L4, L5. You identify psoas. If you do this in a sagittal image and mark the point and go axial, the axial image, maybe it's easier for you to do it. So you take the freehand tool of the many softwares have that image, you can see images, and then you go round the muscle. You do the connect the
For example,
dots
here.
of the muscle. Yes, as you can see here, but you need to do in the both sides. After you do this, the software by itself is going to do the area in millimeters of the muscles, square millimeters. You do you put them both together as a only number and go into the calculator of LURS. I think we have the website. In the first article, they has its shinyapps.io / sarcopenia, if I'm not wrong. It's very easy to use. You need the data of the date of the CT, the birth date of the patient, and the measurements, and they give you a curve. So like Mariana did, yes, just like Mariana did now in the slide. It's easy. It's easy.
And the site, I think is.
Oh, in our article, Mariana,
Yeah,
we have in the methodology, section, we have the link.
Yes.
To the LURS website.
Yeah, it seems pretty simple to do it and to.
It is.
calculate the z-scores. That's amazing. That's an amazing tool that I think not a lot of people are aware of. So thank you
Yes.
very much for talking about this and starting to use it in pediatric oncology. I think this is really, really great for us, and something that we can include in our research and talking about other diagnoses. There is just one comment in the chat. So Joanna is talking about, I think some countries like Mexico, we don't pay the attention to nutrition need, but here I identified that for my patients it's difficult in the cultural way, the change of diet. I mean ingredients, type of food, and flavor. And especially in Mexico, we bring to the city all the cases of cancer, so this talk is very important. Thanks.
Yes.
Thank you, Joanna, for your comment. I think we have a lot of the same problems in Brazil, and the cultural dietary, it's very impactful for our kids, and I think we have to just talk to the families and try to rescue that good quality diet that we have in Latin America, I think, and also in Mexico. I think we have a lot of great options for our patients, and it is something very important to do, and we really have to pay attention to body composition. Yeah.
Thank you very much,
Thank you,
Joanna, for
Karina.
your comment.
Yes.
Thank you very much. And we understand how hard it is in clinical practice, because sometimes patients, they don't want to eat, and we need to like almost dance to make them make them eat. But it's most of important of this is to talk to the family and don't let they go malnourished. And sometimes it's good to us to make a proactive indication of enteral nutrition sometimes, because if the patient is not eating in the first 3 months of treatment, they're losing a lot of mass, and no eating, no food, and bad choices. It's very difficult. Sometimes you need to take the wheel and say, okay, we're going to provide you the nutrition you need, and after we're going back, but now we need to make you like like a fund, like a money fund, so you can expand this for the next months, and then you get the money back by your mouth. But now that you cannot eat because you're vomiting and not working, sometimes you need to go more insistent and more proactive in enteral nutrition, I think. What do you think, Mariana and Karina?
Yeah, it's
Yes.
an important investment, using your
Yes, it is.
metaphor.
Yeah.
It is.
As a
Prevent.
surgeon, I'm more aggressive sometimes.
Yeah. Yeah,
Is
that's
yours.
sometimes it's important. I think we have to understand what is that point, what is that limit. We need to study to figure that
Yes.
out,
We need
so
to
we know
study.
what to do with the patient. Yeah.
Yes.
Thank you very
Yes.
much. Thanks everyone for attending. This lecture will be available on the SciUp YouTube after, so we can all see the recording. Thank you so much, everybody, and see you
Thank you.
next month.
Thank you very much, Karina.
Bye-bye.
Thank you, everyone.
Thank you so much.
Thank you, Karina. Thank you, everybody.
Thank you. Bye-bye.
Bye-bye.
Bye.